Good morning. My name is Adam Seidl. I'm a shoulder elbow surgeon at the University of Colorado. I want to start by thanking Eric McCarty for the opportunity to present. So I'm going to be talking about massive rotator cuff tear, and I'll try to convince you that reverse shoulder replacement is the best option and the way to go. So I'm going to spend a little bit of time talking about the function of the rotator cuff, as well as natural history of rotator cuff tears and the natural history of rotator cuff repair. I will talk about risk factors for failure of repair, which is why reverse shoulder replacement is an option for some patients, and then just go into a little bit of detail as far as who gets a reverse from me when I'm evaluating the massive rotator cuff tear. Looking at patient characteristics is one thing and tear characteristics as another. So just a brief overview of the anatomy. I'm sure this has been hammered in this morning, but rotator cuff is four muscles, one up front, the subscapularis, one on top, the supraspinatus, and two in the back, the infraspinatus and the teres. The function of the rotator cuff is quite simple. It is to keep the humeral head centered and to allow the big muscles around the shoulder to do their thing. So the deltoid, the pec, and the lat. And then obviously in the horizontal plane, the infraspinatus and teres are responsible for external rotation, and the subscapularis is responsible for internal rotation. Rotator cuff disease is a very wide spectrum, ranging from tendonitis to rotator cuff tear arthropathy. So I think it's very important to remember what we're talking about here when I'm talking about reverse as an option. We're not talking about partial thickness, low-grade rotator cuff tears. Obviously, I would not consider reverse in those patients. We're also not talking about end-stage rotator cuff tear arthropathy, where reverse is a no-brainer. What we're talking about is these kind of tears, which are massive rotator cuff tears without arthritis. It's important to understand that rotator cuff tears are very common in general. 30% of the population has a rotator cuff tear, correlates with age. So the frequency of full thickness tears in patients aged 60 to 70 years old is 20%, and it goes up to 80% in patients over the age of 80. Partial thickness tear over the age of 60 is about 25%. So what I tell patients is that if I go on the street and gather 100 patients that are over the age of 60, about half of those patients would have either a partial or a full thickness tear of the rotator cuff. So it's quite common. So we know that it's common, so why not just fix it? Why don't we just repair all these tendon tears? Well, we know that the re-tear rate following rotator cuff repair is quite high. It's consistently reported anywhere between 20 and 50%, up to 70% in the revision setting. We know there are certain patient and tear characteristics associated with healing, and we know that mechanical repair techniques don't seem to alter the re-tear rates. So I think it's important when I'm talking about this and I'm talking about re-tear rate, what I'm likely talking about is lack of healing of the rotator cuff repair. So here's a study that was done, published a while back in JBJS. So looking at 18 patients with large tears following rotator cuff repair, and 17 out of these 18 patients had a re-tear of the rotator cuff or lack of healing of the rotator cuff, and their functional scores, their patient-reported outcome scores, decreased as time went on. So initially they did okay, but as time went on, those scores decreased significantly. Predictors of repair failure. So again, a lot of times these tears do not heal. The biggest predictor of repair failure is age, also tear size, the level of or the degree of fatty infiltration, best visualized on the MRI. Other factors: smoking, the chronicity of the tear, obesity, and comorbidities such as diabetes. So age and size are the biggest predictors of if a rotator cuff repair will work. So if you look here, as you focus on the massive tears, which we're talking about today, patients 50 years and older have a 43% chance of healing, whereas patients 80 years old and older have 17% chance of healing. So really poor healing rates overall once you get into that massive tear category, and very poor once you're in that 70 to 80 year old age range. So options other than repair, which a lot of these have already been discussed. So simple debridement, which is something to consider, biceps tenotomy or tenodesis, tendon transfer. Again, I'm going to focus on reverse shoulder replacement and then superior capsular reconstructions. So why reverse? Why do I recommend a reverse in some of these patients? There are predictable results with reverse shoulder replacement, in particular pain relief. So most of these patients get quite good pain relief, restoration of forward elevation. So most people after reverse shoulder replacement are able to get their arm up over shoulder height over their head, and the patient satisfaction is quite good after reverse shoulder replacement. The other thing to consider, and this is not the reason to do the surgery, but it is something that patients are interested in, is the length of recovery. So my general rule is that for rotator cuff repair, patients are going to take a full 6 months, if not longer, to recover. This is the same for superior capsular reconstruction. For a tendon transfer, it's typically greater than 9 months. For reverse shoulder replacements, most patients are quite happy around the 3-month time point. They have really good pain relief. They have restoration of function, maybe not full function or their maximum function, but they're in a pretty good spot at 3 months, much quicker than the other surgeries described. So how it works, so quite simple. I told you before that the rotator cuff functions to keep the humeral head centered on the glenoid so that the deltoid can do its job. When the rotator cuff is deficient, a reverse shoulder replacement can serve that function. So it stabilizes the joint. It allows for a fixed fulcrum for the deltoid, and it allows for the deltoid to work and lift the arm up over shoulder height overhead. So who gets a reverse? In my practice, this is older patients with a massive tear, patients with a true pseudoparalysis with a massive tear, any massive tear with underlying or concomitant glenohumeral arthritis, and then patients with multiple other risk factors for failure of alternative treatments such as SCR. So this includes a irreparable subscapularis and multiple comorbidities such as diabetes. So this is a symposium to discuss athletes. So why am I talking about reverse shoulder replacement? There have been several studies actually recently looking at return to sport after reverse shoulder replacement. So in general, the return to sport is very high, greater than 80%. Now, these are different sports than we may be talking about otherwise. I'm primarily talking about golf, tennis, and generalized fitness, as well as swimming. So if you look at the numbers, about 84% of patients were able to return to swimming, 77 return to golf and fitness, and almost 70% return to tennis. So those rates are quite high after reverse shoulder replacement. So in conclusion, massive rotator cuff tears often can't be repaired, and they have a very high rate of not healing. Age is the biggest risk factor for failure. Reverse shoulder replacement should be an option for these patients, but patient selection is very important. The surgery is not for everyone. It's typically not for young patients, just given the longevity of the implants. It does produce predictable outcomes in the right patient, and most of these patients are able to return to sport. But again, those sports are typically golf, swimming, or tennis, as opposed to any higher level or contact sport. I apologize that I won't be able to be live to answer questions today, but do not hesitate at all to reach out to me via email if you have any questions about this talk about reverse shoulder replacement. Here's my email. And once again, thank you very much for the opportunity.